Good morning, folks. My name is Martin, and I will be your moderator today. And welcome to Friday Chalk Talk. One little piece of housekeeping before we get started, and that is that we have spring break the next 2 weeks. So no Friday Chalk Talk for 2 weeks, and we'll see you guys in June. Today, we've got a couple of fabulous guests. We have Adrian and we have Sean with us, and they're here to share a discussion about their recent publication that is titled The Pitfalls of Utilizing Goals of Care as a Clinical Buzz Phrase, a Case Study and Proposed Solution. So welcome, guys.
Thanks so much for having us.
Thanks.
Absolutely.
Appreciate it.
Today's format's going to be 2 parts, and it assumes that you've already read the article. So in the first part, I've got a handful of questions that'll explore their topic. And then second, we'll open up the floor for discussion. If you guys have any questions or if you guys have any shared similar experiences, which I bet that you do. So with that, thank you everybody for being here, and we'll jump right into it. So Adrian and Sean, tell us a little bit about your current role in palliative care and how you got interested in this paper's topic.
Should I start? Okay. I am a palliative care doc. That's what I do full time at Freighter in the VA. How I got interested in this topic, I think it really starts way back when I was a fellow. I mean, it's impossible when you're doing palliative care work not to notice that the most common reason we get consulted is help with goals of care. I do remember, I don't know if Sandy or Ruth is on, but I used to work really closely with both of them, Sandy Mushka and Ruth Drzezuski. And I remember we got like this consult that it was a patient that had been readmitted a number of times. It was a very complex case. And that we are strategizing before we saw the patient, like what's the best approach we should take? What would be the most constructive approach? And I remember the consult question this time was goals of care. And I remember just thinking in the back of my head, it's like, oh my gosh, why are we even strategizing? This is going to be so easy. And so my strategy that I had in the back of my head was I was just going to walk in and ask the patient what their goals of care were. And I remember I tried it and the patient just looked at me like, huh? What are you talking about? Like, it didn't go anywhere. And I think I was thankfully with either Sandy or Ruth, and they completely bailed me out. And I watched them lead a very constructive consult and learned a lot from it. But that was kind of the first aha moment that this phrase goals of care, we use it a lot. It's how referring teams and us kind of communicate that our services are needed or bigger discussions are needed. But it's sort of like a buzz phrase, like it doesn't have a tangible meaning, I think, sometimes to patients. And then because of that, like over the years, I've just noticed some miscommunications that have happened where referring teams consulted us for goals of care. We thought they meant something, and that propelled us to approach the consult a certain way, only to reach out to the referring team and realize they were looking for something completely else. And like we had different ideas of what the concept of goals of care were. So that's kind of how it started. Adrian, do you want to give your background?
Sure. Yeah. So I am at the VA for my clinical time. I also round on the inpatient general medicine wards and do the consult service in our palliative care unit here. And I also sort of got interested in this topic when perceiving, especially on the medicine wards, this sort of disconnect between what's expected from a goals of care consult and what actually happens and what we actually do. Sean sort of came up with the idea and had already started an outline for how to standardize goals of care to try to help, lessen this disconnect and make it a more, more like a recipe and easier way in which teams sort of understand what goals of care mean. And, I say, I feel like goals of care sounds like a buzz phrase or a buzzword to a lot of people. And even to me, like, what does it actually mean? What are we actually doing? And so when we started, researching more and writing the paper, we kind of fell into a lot of different definitions and made hopefully a better approach that we can standardize.
Wonderful. It's nice, Adrienne, that you get a chance to see it from both sides, working in the hospitalist world and the palliative care world.
Yeah, I really do enjoy that intersection, but in my work between palliative care and when I'm on medicine wards, I feel like it's really helpful to sort of step back and see the big picture and kind of watch the residents and the light bulb go off on, hey, let's ask like surprise question, or just kind of figure out, okay, maybe this patient needs a goals of care conversation. It's been fun.
Wonderful. So in your guys' paper, you described a case all too familiar for many of us, where there was breakdown in communication, and in particular, breakdown with the use of the term goals of care. So what did you guys find as a result of your paper, and how do you hope that it results in change in our practice for the future?
Yeah, I think the case in some ways is very almost cliche. I don't think there's anything really novel or unusual about it. I think it'd be very recognizable to both hospitalists, referring providers, and palliative care doctors. And that's why I thought it would be a good case report, because when you look back at just kind of the usual day-to-day cases that we get, there's a lot to learn from it. And I think there's a lot of opportunities for improvement. One of the first things that Adrienne and I kind of noticed is, like, this case exemplified that maybe 10, 12 years ago when I started practicing, Freighter at least was not quite as big of a hospital. And all our team rooms, we were all kind of just packed in team rooms. And so when you wanted to get a consult, it wasn't that hard to just walk down the hall and teams would chat with each other and they would chat it out. And I think it would be a lot of the nuances of what teams were looking for would get communicated better. A lot has changed since then. And the way consults are called in and how we're busy and we're trying to maximize our efficiency, I think just opens up a lot of opportunity for miscommunication right there. And part of the case just explains where the hospitalist paged us. We got a communicator who communicated to us what the hospitalist wanted the consult for. It's essentially for goals of care. So I think it highlights like all these factors, these day-to-day factors that lead to like kind of breakdowns in communication between doctors. But I think the bigger message is it just, when you say I want palliative care to see you for goals of care, I think it leaves a lot, it's so abstract that it leaves a lot open to interpretation. And I think one thing that I'm hoping for our specialty is we can kind of get out of the approach that, hey, we're the communication experts, and that, we're like some black box. Like, you consult us and who knows what happens, but at the end, everything's perfect. Like, the perfect communication happened, everything, perfect information was shared and things like that. Sort of want to get out of that, because instead just hoping that we can standardize our approach a little more so that people just have a more reliable sense of how to approach goals of care in a more sensible way so they could do it themselves. And it's just a little more reliable what a palliative care consult will entail. I think it will lead to better communication between teams, and hopefully it'll filter down to better care for the patients. Those are my thoughts.
Yeah, and I agree. I think a lot of the just sort of what I came across when helping to write our paper was that the frustrations of those communication gaps and multiple variables and increasing complexity in the system became more understandable. And even when I'm, on the medicine wards, I find it challenging to sort of bridge that outpatient relationship and the communication that goes on there with what I'm seeing with the patient in front of me and what, the residents are viewing and hearing from families and patients when I'm not there. And I think, the complexity of the system makes it really hard to have a good discussion about what you want to achieve out of a goals of care consult. And it kind of makes us worry that, it's goals of care becoming this sort of dangerous phrase that is getting thrown around that is hard to define and hard to conceptualize, and sort of leads to these breakdowns in communications, that we talked about in the case. Another example we were thinking about the other day was, for instance, like a patient who's coming in with end-stage cirrhosis, and no one really knows if they're a liver transplant candidate or not. But that's, step one, like,
Sure.
Is this patient, because the goals are going to be really defined by, what the answer to that question is. And so a lot of times it kind of seems like, we have a lot of different providers that are giving different opinions and may not agree on just the basic medical issue that the patient is, the patient and family are facing. And it's, I think sort of the paper sort of enlightened me on, how do we best set the medical scene? How do we help understand first and foremost, what are the medical options and what are the goals, and have that basic idea of how to really provide context in these conversations. And, I think part of avoiding some of these communication breakdowns is, having sort of more of a standardized approach and have the same expectations of what is going to happen when we see the patient versus, when the primary team is talking with the patient. So another interesting example I just thought of too is my husband's an orthopedic surgeon in private practice, and he primarily practices out of Waukesha and Oconomowoc. And the consults that he receives are through the HUC or the HUC, the health unit communicator, and he doesn't even have a direct conversation with the provider. So he literally gets called and the HUC says, this patient's having knee pain, you need to come evaluate him. And that's all he gets.
Sure.
And so I think it's just, it's helpful to kind of have, more of a, sort of a good understanding of what we do. And hopefully, we can provide the tool set and the better understanding and clarity around the concept of goals of care.
Yeah, you're speaking to the choir, man. We have the same thing where we have all the consults go through the HUC. Sometimes the person who placed it was the night hospitalist, and there's no way for us to possibly reach them and find out
Right.
what it is that they actually want. So we're faced with this struggle of understanding what it is. Sort of a two-part question for you is, why do you think it's such a challenge to get consultants to elaborate on the term goals of care? And can you guys share with us a tip that you use to help you tactfully, maybe lovingly, get more detail from your consulting colleagues of what it is that they want and why?
Yeah, I think at least at the places we practice, sometimes the request, when you look at what germinated the request for getting palliative care involved, it might not have even come from the team. It might have come from the bedside nurse
Or the patient.
or
Or the family, yeah.
the family, a social worker saying, hey, I think you should get palliative care involved. So sometimes the primary team, they just know that something's not working, that they're giving the usual medical therapies that normally get people well and better, but this patient's not getting better, or disposition's very challenging, or there's some disconnect in the communication or symptom management. So they have a sense that something's wrong, but they might not have articulated to themselves exactly what is wrong. And so I think that leads them, when they call on the consult, they know that, I think they're anticipating, as long as they use the phrase goals of care, we're going to be like, oh, okay, goals of care. Okay. All right. Yeah, we'll go see him. It's sort of like when you, I do a lot of editing, and sometimes people write a a paper and you're wondering, what's this patient population you're talking about? Which patient population? And they're like, oh, well, I'm talking about patients with serious illness. Oh, serious illness. Okay, got it. I know what you're talking about. But really, these are like very poorly defined terms. So I think on our end, if we can just pause, I think like taking the extra step of reaching out, even if it is called into the HUC, and trying to talk with somebody on your team, on the referring team, just get a little better understanding of, yeah, like Adrian hit on so clearly, like what are the treatment options? What do they feel is a reasonable primary goal of all medical intentions? And really, there's only 3, maybe 4 of them. Like, are we shooting for cure of the underlying illness? Are we shooting for life prolongation? Or just, do they feel like we're at a stage where only comfort's reasonable? And so I think the first step is getting that sense from the referring provider. And then honestly, a lot of times what we do in our goal for initial consult is just get a sense from the patient. We just see if they match up. And if they're completely different, that signifies probably we need a goals of care conversation. And sometimes it's just as simple as that.
Yeah, I think it's just reflecting it back to the team and saying, if we're gonna, we're happy to come help with a conversation, but let's take a step back and say, it seems like this is what's happening, and sort of maybe help define what the medical reality is, and try to understand, what more of like the longitudinal perspective for a patient. I think is, especially on the wards, I find that you're seeing this patient in front of you who's really sick and just not able to participate in physical therapy or some issue that's preventing them from moving their care forward. And so therefore they think, as Sean was alluding to, that something, we're not progressing their care. And so now we have to call palliative care, and to like further elucidate on what their goals of care are. And so, once they reach that point, it's, kind of stepping back and saying, okay, well, what was life like? I kind of find it helpful to talk about, what life was like with the patient over the last 3 months, or what some of their outpatient doctors are talking with them about, or kind of, providing more context and perspective to help really define what the medical reality is, so that we can have sort of a productive and efficient conversation that's the same every time. So it's more like a habit than sort of a this black box of, hey, just come fix it.
Yeah. I think in an effort to try to move to the discussion, I'll ask you guys just one more question and then we'll open it up to everybody. So I think my final question is, if you really had the power to make any one change in medicine on this particular topic, what would you change and why?
The video visit.
Oh yeah,
I think what I would love is to have this perfect communication between the outpatient docs and the inpatient teams. Even if you could just get them on like a 2-minute video clip to show to the patient that they're participating in these very vulnerable and challenging conversations and next steps, and say, look, your oncologist, your cardiologist, your cirrhosis doctor, this is what they're thinking about where you're at, and what is sort of next for you. And I think that would just do volumes for trust and provide a lot of support for the inpatient teams. That's my wish.
Yeah, I could see that. I mean, like, I think for where we practice, it's very difficult sometimes for the oncologist, for example, to come into the hospital, see the patient, and give the longitudinal perspective. They might not even have time to like be able to sit in on a Zoom meeting with the patient and the family, or be on the phone the whole time. But boy, if you could just get a little snippet of their video, just like kind of summarizing where their cancer's at and what they feel like could be good next steps, that's something we could utilize then in a meeting. And instead of quoting the oncologist, I could see that working well.
And then more like acceptance with recommendations against futile decisions, and just sort of less distractions and noise around things with poor outcomes, like just recommending DNR, like having an acceptance of that recommendation rather than having that as an option, would also be cool.
Wonderful. All right. Thank you guys. I really appreciate your time. Let's open it up for discussion.
All right.
There's Wendy.
Marty asked me to just pop in. I popped something in the chat. One, thank you for deep thoughts on this and for bringing it forward. I do have to say I find myself cringing a lot when I hear that term anymore. And I thought, my question to you is, I find that it's become such a buzzword that we use it in front of patients and families. And I've heard providers say directly, we're going to talk about your goals of care. And they, like you say, they look at people very puzzled. So I was curious in your research and writing the paper, if you had thought of another phrase that we should use with patients and families. And the other was, do we ever have these conversations when things are going well?
Say that last part.
When things are going well, is there such
Oh.
thing as a goals of care conversation when someone's doing well?
Oh, yeah. They're hardly ever calling us in to break good news, are they? Yeah. Oh, those are good questions. Yeah, I think that one of the goals of care is not like as I learned kind of the hard way, through experiences as a naive fellow and even naive attending in my early years. Yeah, it's too, I think, just abstract of a phrase for, and too just kind of large. And I'm trying to even imagine outside a medical setting, if somebody that I didn't know very well and I struck up a conversation, they said, hey, what's your goals of, I don't know, working? What's your goals of working? It's like so big, it would just put you on your heels. So I think, I guess one thing we did to try and, because that was a question, I'm not sure I have a great answer to it, but one thing Adrian and I decided to do for this paper is we decided to look through the evidence-based literature and just try and look at what are the definitions out there for goals of care. And we found a bunch of them, but primarily they kind of fell in two camps. One is there's goals of like medical interventions, and then there's patient-centered goals. And I find that it's very hard to elicit patient-centered goals until you have a fundamental understanding of what are reasonable medical goals of therapy. And I feel like you have to establish that first. So I sometimes will start by, Wendy, to your question is, let's say a patient has cancer and maybe they're getting chemotherapy for their pancreatic cancer. I might ask them, what have the doctors told you is the intent of this chemotherapy? Are they trying to cure your pancreatic cancer? Are they trying to manage it so you can live longer? Are they just trying to make you comfortable and treat symptoms? What's your understanding? So I'll kind of ask them that way. And I think once you have a tangible understanding where we're all on the same page of what are the primary goals of medical therapy, then a lot of the other stuff that we have to sort through, do you want to be DNR? Do you want to be rehospitalized? Do you want antibiotics? It all is put into that context of the primary goal of medical therapy. So I think the discussions tend to be more natural.
Genuine,
Yeah, genuine.
Yeah.
And it's a little less of the menu sort of thing. And then once you have the primary goals of medical therapy established, then you can kind of start to work towards the patient's individualized goals of care. And I just find that flow works a lot better. So it's sort of like a two-step process.
Yeah, and then to echo off of that too, I think sometimes I find myself thinking about, okay, what are the expectations of the hospitalization? What are the expectations of what does the patient think their expectations are, and the family, and then how does that match up with what they're wishing for or hopeful for? And I find, some of those words easier to talk about, maybe because they flow more naturally than just having this catch-all goals of care term. And it kind of, it sounds like a cliche when we're talking like that with patients. And yeah, it just doesn't feel as like natural and genuine of a conversation, but just kind of trying to be specific with the language as it relates to where the patient's at in their illness and what they're hoping for.
Steve, I saw you had your hand up.
Yeah, and just for your reassurance, I'm parked right now. So I am trying to figure out how to formulate the question, but I agree that we're overusing goals of care and we're getting flooded with consults for goals of care where it's not even clear sometimes where it's coming from. And do you have any tips for talking to the referring provider about what we're trying to decide? Because I find it very difficult to engage in a goals of care discussion if I don't even know what we're trying to decide. So in my head, before I engage with a patient, I try to decide a clinical question or a problem that we're trying to address. And a lot of times it seems like we're getting referrals, maybe sometimes generated by nursing or case management, where they just know the patient's going to get readmitted and they want goals of care clarified. So tips for kind of negotiating that.
Yeah. So, and sometimes it's just like on the front end, you feel like you don't want to like give the impression that you're blocking a consult or anything like that. On the front end, I think it's okay to ask some leading questions, but if you're not getting too far, sometimes I just think it's like easier just to do the consult and spell out my thought process. Like, and sometimes the thought process, hopefully, if you can spell it out clearly and really succinctly, then it starts to hopefully dawn on the primary team. For example, like a liver transplant patient, like everybody might be saying, well, what's their goals of care? What's their goals of care? Well, it's pretty obvious. Their goal of care is to get cured. They're hoping to get that transplant, maybe. I mean, this is just a hypothetical scenario. So is it really a goals of care conflict? They say that transplant could be an option if they do these 10 things.
Right.
They're saying, well, I know it's a low chance I'll get it. I'm willing to undergo all, potentially burdensome medical interventions to get there. Yeah, sign me up for the cure thing. So I think just kind of articulating that, just barfing it up in your note and just saying, hey, this is the approach I took. Their goals of care cure. You're telling us that you're willing to offer a curative therapy if these things happen. And then say, if this does not seem like a reasonable option, let us know how we can help. I don't know. I'm not sure I've come up with a better strategy than that, Steve, unfortunately.
Yeah, and I think part of the discussion between the referring teams and our consult service is sort of finding that way in which to help the team understand what they want for the patient versus what the patient wants for the patient too, and kind of how Sean was saying, like, well, maybe they need more anticipatory guidance on what a cure or transplant might entail. So that might entail a lot of medical burden in the next several months, but if that's their ultimate wish, then their goals coincide with that. And it's sort of providing more context and trying to maybe see like what is the referring clinician's bias, like what are they hoping to get out of the consult. I feel like sometimes there's that disconnect between what we want for patients and what the patient is looking for, wanting as well, and sort of kind of reducing it into that, like, okay, do they want cure? Do they want sort of rehab and life prolonging interventions? Or are they sort of ready for comfort care?
Yeah, and the last thing, just to piggyback on what Adrian said, it's one thing I've learned from my colleagues like Dr. Jonathan Gooley and Wendy Peltier, Katie Reka, so many like great colleagues I work with, is as I read their note when I'm covering them, I notice that they're always like exploring patients' worries, like they're identifying the goals of care that I want to get cure, but they're also exploring what worries them, like what fear do they have about exploring that. And sometimes just naming that in the note can be helpful to the referring team, and then so that they can act on it, I guess.
Yeah, or have insight into what the patient's like really thinking or what they're not asking too is helpful, I think.
Hey, morning, guys. Paul Stellmacher, one of the faculty at MCW, for those on the call who don't know me. I think I threw it in the chat, and actually I think we managed to naturally get to this. Perhaps semantics, my challenge with calling it goals of care is that there's an objective, there's a target, and that's, I think, what you were just talking to, is that whose objective are we trying to ascertain? Whether that's the primary team actually has an idea of what they think's right for the patient. And Adrian, I know, like Adrian, I also do hospital medicine, and I find when I'm on that side of it, my brain's not thinking in the concept of goals of care. I'm just talking about, hey, this is what we're doing. This is what I hope to achieve. Is that in line with what you're hoping to achieve, or whatever? And it doesn't feel like I'm doing goals of care, even though I think that's what's happening. So that's one of my own struggles. It's just that it implies there's a target, there's an objective. And so I think then on to my next comment, and this was kind of playing off Wendy's goals of care when things are going well. Whether this is right or wrong, like when I talk with learners, I view it personally, I guess, as a spectrum. Like when you're healthy and well, it's advanced care planning. When decisions are needed, when we are at that point, then we're calling it goals of care, but it's just a spectrum of the same conversation. That's how I kind of view it. And so, whether that's we are ultimately trying to align a care plan with a patient's priorities, however else we describe that, that's kind of how I view the process, because I think goals of care is a process rather than rather than a specific thing we are achieving when we talk to patients and families. And that process looks different for each encounter, which is what I think everyone's discussed. So those were my thoughts, less of a question.
Thanks, Paul.
I think the discussion got there after I had thrown them in the chat. So
and Sean and I just pulled up the chat now, but apologies about that. I'm seeing April's note too about low prognostic awareness and unrealistic expectations from the patient or family, interconflict issue, like complex disposition, I find is a common trigger for goals of care conversation. And it's again trying to understand, okay, what is your hope for us to do, and sort of trying to standardize it so that we're sort of making it less of a buzz phrase, perhaps, and sort of naming that. We're obviously good at naming emotions, or maybe not so good, but just kind of trying to figure out what the team's expecting, I think is helpful.
And Paul, one of your phrasings there, I think is a really good one to ask primary teams when they're calling in the consult for goals of care is, what do you think is best? Like taking out all the psychosocial information, what do you think medically is best for this patient? I think is a good question to ask, especially when it's maybe like a doctor in training, because I don't know, somehow the way we've constructed, I think, training, we've kind of gotten away from that. And instead kind of, I think more of the focus on training, at least in internal medicine sometimes, is getting all your orders in, doing all the kind of day-to-day tasks of medical care, that sometimes we forget to like encourage that doctor who's in charge of all this. What do you feel is best for the patient? Kind of lead with that. So I think that's like a good, Steve and Martin, you both asked, like, what's a way where you can ask the, kind of ask the primary team to think about goals of care in a different way. And maybe that's like a great way to first start the conversations, like get a sense from them, what do they recommend for this patient? And then
to help elaborate on why they're consulting us.
Yeah.
Right.
Wonderful. All righty. Thank you, guys. Thank you, everybody, for your generosity and time this morning. It was a delight having you guys both here with us today.
Thank you.
Thank you.
Absolutely. Have a great weekend, everybody.
You too.
Bye-bye.
Bye.